Welcome to Menopause Reimagined. I'm your host, Andrea Donsky. I'm a nutritionist in menopause, menopause educator, and menopause researcher. I'm also the co-founder of wearemorphus.com. I'm excited today because we were named by FeedSpot one of the top 10 most popular menopause podcasts around the world. So thank you to all of you who listen to our podcast, who share it, and who leave reviews. We are helping so many women take control of their health and their overall symptoms with nutrition, lifestyle, and supplements. Today, I'm speaking with Dr. Christy Sutton. She's a chiropractor who's interested in asking why health problems occur, what the root causes are, and what are the safest and most effective solutions to health problems. Her book, The Iron Curse, which comes out in September, is inspired by diagnosing her husband and many patients with hereditary hemochromatosis and other iron related health problems. From her experience as a clinician, she has discovered that there is a silent epidemic of undiagnosed and untreated hemochromatosis. Now, here's Dr. Sutton. Welcome to the show, Dr. Sutton.
Thank you.
So I found you on Instagram and I saw your post and I love what you talk about. So I asked you to be on the show. So I'm very grateful that you said yes to come on our Menopause Reimagined podcast. And I wanted to talk about something that I know you're an expert at, which is iron. And can you tell us a little bit? I had done an interview with Dr. Thomas Pearls. I'm going to put a link below for those of you who didn't listen to it. It was really eye-opening for me in terms of, how iron can affect women, especially in menopause, once we stop cycling and that we're not shedding blood every single month, we're not getting our cycle, and how it can actually accumulate in our system. So I want to dive a little bit deeper into that because I know you talk a lot about that and you wrote a book on it. And then if we have time, I really want to talk about methylation also. So two areas that I think we haven't really covered in depth on our podcast, and I think it would be really interesting for women in this phase of life. So tell us what got you interested to talk about iron in the first place.
Yeah, so my first book, the book Genetic Testing, Defining Your Path to a Personalized Health Plan, as I was writing that book, I wrote about the hemochromatosis genes, and I discovered that I was doing genetic testing on myself and my family and lots of patients, and I discovered that my husband had inherited one of the hemochromatosis genes, which makes you absorb more iron and can increase your risk for high iron. And I had been kind of looking at the labs that he brought home from his primary care doctor, and there had been a couple different times where he either had a high ferritin or high hemoglobin or hematocrit or red blood cells. And I would recommend to him, you need to go and donate blood. And his primary care doctor that ordered the labs wasn't saying anything. And so occasionally he would go donate blood and listen to me, but it wasn't being managed properly. And then when I realized he had that gene, I realized, oh, okay, this is what we're really dealing with. And this is not, just by happenstance, and it's not going to go away because this is a genetic issue. And then ultimately we had to get an official diagnosis because his liver enzymes were slowly creeping up, because high iron will destroy many different parts of the body, but it's particularly hazardous for the liver. So that's often one of the first parts of the body that gets damaged. So his liver enzymes were slowly going up because of the high iron. But iron, it destroys the liver, it'll destroy the testes and ovaries in females, it'll destroy the heart, causing cardiovascular issues, it'll destroy the pancreas, causing blood sugar issues, it'll destroy the anterior pituitary gland. And so it creates a lot of infertility type issues and hormone issues. And we went through the process of getting my husband officially diagnosed with hereditary hemochromatosis, which was a much more complicated process than it should have been, because he was basically, the doctors were not recognizing what it was despite kind of my giving it to them. And so we went down a misdiagnosis rabbit hole, then we finally got him diagnosed, and then we discovered it was kind of the light there at the end of the tunnel. The light at the end of the tunnel was a train, because after we discovered that he, had hereditary hemochromatosis and treated him for that, I had been watching his labs closely, checking his hormones, and his DHEA and occasionally his cortisol was slightly high. And we realized that I thought that was high just from the stress of high iron, because high iron can do that in addition to just stress from a stressful job, which he had. So the iron came down, but the DHEA and cortisol did not come down like they should have. And so we went to the endocrinologist and lots of different tests, but eventually we found out he had a pituitary tumor that was causing him to have Cushing's disease, high cortisol. And so, because he was secreting too much ACTH from his pituitary gland. So I have no way of proving this, but my theory is that it's not just a coincidence that he has a tumor on the anterior pituitary gland, which is one of the areas that it really gets damaged by high iron. I think it was just, high iron created a lot of oxidative stress and damage and DNA damage and, perfect storm, and he ended up getting a tumor. I have no way of proving that. So anyways, after going through all that, I'll summarize this up real quickly, but after going through all of that, I became very sophisticated at looking at, I had already been looking at the iron, but I really kind of looked at it again in terms of like looking at the hemochromatosis gene. And I realized that there are so many people that are undiagnosed with high iron, and a lot of them, most of them, have one of these hemochromatosis genes that make them absorb more iron. And then eventually, I just got so tired of seeing this person after person, and I would refer them to a hematologist or to their to their primary care doctor, and they would get kind of poo-pooed and dismissed, like that's not a big deal. And so it was very frustrating, and thus I created the iron curse because of that.
So how common is hemochromatosis?
Yeah, so it's largely undiagnosed. If you look at the official numbers, if you were to Google it today, then it would say around 1 in 300 US non-Hispanics have hereditary hemochromatosis. If you were to look in Ireland, Northern European, especially the Ireland, UK area, it would maybe say up to 1 in 150. Having said that, those numbers are grossly undercounting because those numbers are looking at the diagnosed population, and only about 2 out of 10 to 1 out of 10 people that have hereditary hemochromatosis get diagnosed. So it's one of those things that there's really kind of a silent epidemic going on right now where people have this at a much higher rate than is truly being diagnosed. And so they're not counting those people. It's one of those issues where if you're not counting it, it doesn't exist. But it's a serious issue. Otherwise, I wouldn't be seeing it routinely in my patients. So I know that the numbers are way undercalculating. I just don't know exactly how much.
So how do we diagnose hemochromatosis?
So hemochromatosis is diagnosed on blood work. It's really an easy and inexpensive thing to diagnose. The problem is that it takes a full iron panel, which is not very expensive. Having said that, most doctors are not ordering a full iron panel. Most doctors will maybe order a serum iron or a ferritin, or maybe they just won't even look at iron and they'll just get a CBC. So, if you get a CBC, then that's this complete blood count, then that's going to be looking at your red blood cells, hemoglobin, hematocrit. And that does not include your iron levels, because you can have like low red blood cells, low hemoglobin, and still have high iron, and that's called iron loading anemia. So you really need a minimum, and these are not expensive labs, a minimum, a full iron panel, a CBC, and complete blood count, and then a CMP comprehensive metabolic panel. Altogether, you should be able to get all of that around 70 to 90 US dollars, just depending on where you're ordering it from. But this is totally, within the scope of normal doctors. They're just not ordering these labs, but it's diagnosed. So hemochromatosis is diagnosed by looking at the iron levels in the blood. Hereditary hemochromatosis is diagnosed by having both high iron saturation and high ferritin in the blood combined with one of those hemochromatosis genes. So if you have one of those genes plus having high iron, that's hereditary hemochromatosis, which is the majority of people that have hemochromatosis. Having said that, there are a lot of people that don't have a hemochromatosis gene that still have high iron, and that's called non-hereditary hemochromatosis. But it's always diagnosed based on blood work, which is why it's really unacceptable that there's so many people that are undiagnosed.
I recently asked to have a full iron panel done and the lab wouldn't do it. They just looked at a couple of things. So,
Really?
yeah, it's very interesting because they'll look at ferritin. And I think that, yeah, very interesting to me. And it was said on the results page. I'll actually have to I'm going to I don't have it in front of me because I didn't know we would even talk, like we were going to bring this up, but I'm going to read you exactly what it said. And they said that they wouldn't do, it was asked for, but they wouldn't do it based on the results of specific tests. But I'm going to get that information for you because I thought it's
Yeah.
interesting.
Yeah, so it's really common that labs, and this is an insurance-based problem, like insurance is driving this problem, which is basically they'll say, we'll only order this lab if this other lab's out of range. But that's a fallacy. That's a fallacy that's costing the insurance companies even more, because if you're missing people with, if you're ordering full labs on people, a really thorough lab panel, you realize how many people have issues that you would have missed if you had done that insurance-based, protocol where you go through the, if you get this, then we go to this lab and then this lab. Sometimes you just have to kind of be thorough, and a full iron panel is easy to be thorough on, but that's really interesting. I wonder if that's because you're in Canada.
I'm not sure.
I don't
I
know.
don't know. It was the
It,
first time that I had ever seen actually something like that. So I was kind of like, oh, this is interesting. So,
yeah.
so Dr. Sutton, can you tell, so for those who are listening to our podcast, we like very, at least, for me, I really like to explain it so it's very simple for our listeners to say, okay, I got my plan. I'm going to go and I'm going to ask my doctor for this. So you mentioned a lot of blood work. Can you kind of break it down? It reminds me a little bit about thyroid because,
Yeah.
for a thyroid panel, we need 6 tests for thyroid. But most of the time, our doctor will only test TSH. If we're lucky, free T3, free T4. Then we have to, ask to get the antibodies test. Maybe they will, maybe they won't, and the reverse T3. So it kind of reminds me a little bit about that when we're talking about getting panels done. So I would love you
Yeah,
to
me
go
too.
into the detail.
Yeah.
What is it that we want? So for those of you who are listening, grab your phone, grab a pen and paper, grab something, pull up your notes. What are the tests that we should be asking our doctor for to test?
Okay, yeah, yeah. It reminds me of thyroid too, so much. And my hopes is that with the iron curse, it's going to be like this explosion of people that kind of get diagnosed. And I think it's ultimately going to kind of come down to the layperson like driving it, because it's clear that with this high rate of misdiagnosis and undiagnosis, the medical profession has kind of lost the battle. So the labs I mentioned include, and I'm talking about a bare minimum. Now, in the iron curse, I go through many other labs that you need to have in addition, really, to monitor your health for iron related issues. And then there's this whole other issue of looking at copper. And for the sake of not like overly complicating things, I'm going to start with the bare minimum that if you go to a primary care doctor, they're going to know what these labs are. They should be able to order them. So the CBC, complete blood count, which almost all doctors order, routinely. The CMP, the comprehensive metabolic panel, which includes your liver enzymes, that includes your kidney function, electrolytes, that type of stuff. And then the CBC has your hemoglobin, hematocrit, red blood cells, white blood cells, that type of stuff. And then the last one is the full iron panel, which includes the ferritin, serum iron, TIBC, UIBC, and iron saturation. So if you have those 3 panels, basically, then you should have enough information to tell you, do you have hemochromatosis? And then you can look at, are you developing high red blood cells, high hemoglobin, high hematocrit from high iron, which is a common issue because the body is trying to store that iron, and it stores it often in the blood as hemoglobin. And so it's a common issue where people that have high iron will develop high red blood cells, high hemoglobin, high hematocrit. And this is a problem because it's a clotting risk. If you have high hemoglobin, high hematocrit, high red blood cells, you're more likely to have thicker blood. You will have thicker blood, and then that's a clotting risk. So these are people that donating blood is a really good option for them. But, of course, you need to, and not everybody can donate blood, but there is a way for everybody to have blood removed. You just might have to ask your doctor about, doing a therapeutic blood draw. And then that last part the CMP, that's going to like tell you, are you having issues with your liver from high iron? And not everybody that has hemochromatosis, high iron, develops high liver enzymes, but it is a common pattern, and it's often one of the earlier patterns to see. For example, in my husband, and he wasn't and has never been a big drinker, so it wasn't like an alcohol-induced liver type issue. And even sometimes in people that do drink a lot, their liver enzymes don't go up that quickly or that easily. So everybody's different. But certainly you want to look at those labs. And
Yes.
everybody needs to have those done at least once a year. Now, to figure out if you have the genes, the way that I get the genes done on people most often, I don't care how people do it. It's just, I typically go direct to consumer through 23andMe. And then, 23andMe will sequence the hemochromatosis genes for you, regardless of which package you pay for, from the cheapest to the most expensive. If you pay for the cheapest package, they won't give you your hemochromatosis genotype, but then you can create the genetic detoxification report that I created that report. And so, you can use your 23andMe raw data to figure out if you have the hemochromatosis genes, and then like over 300 other genes. Personally, what I would do, including the MTHFR genes that we're going to talk about, I think.
Yeah.
But personally, what I would like to do whenever it's me personally or my family members, I'll pay for the most expensive 23andMe plan, like to get all the extra stuff. And then I'll also get that genetic detoxification report, because I just want to get as much information as possible, and then kind of create a personalized health plan moving forward from that.
Yeah, I love genetic reports. We work with the DNA company, we work with GeneRx, and is this a genetic report that you're able to offer to your patients that they can get? Okay.
Yeah,
So they
it's
can
to the
get somebody.
public. You can just go to geneticdetoxification.com
Okay.
and create, if you have 23andMe raw data, then you
Yeah.
can create that report. Just, like you can create a lot of other reports out there. And then my first book, The Genetic Testing, Defining Your Path to a Personalized Health Plan, that's really designed to go along with that report. That was kind of the whole reason I created that report, was so that people could read that book and learn about the genes and then get their genotype, and then kind of know what they need to do as far as nutrition, labs, symptoms, etc.
I'm glad that you mentioned symptoms, because I want to go there next. What are the symptoms that we should be looking for if we were, obviously like you recommended, we get the test done once a year, but what is it we should be looking for? How would we feel if we had hemochromatosis?
Yeah, so that's a good question. And what comes to my mind is, I have this image in the Iron Curse of this iceberg, and there's, the symptoms above the iceberg and then the symptoms below.
Yeah.
And basically within that iceberg, there's, the tip of the iceberg is like fatigue, joint pain, maybe menstrual problems. A lot of females, they'll stop having a menstrual cycle because it'll mess up their hormones, or they'll just have infertility, like a low AMH, anti-Mullerian hormone, the ovarian health fertility hormone. But it can cause liver disease, which, if that goes long enough, then yeah, you'll feel that. But a lot of people, they don't feel liver disease, they just maybe have hangovers that are worse than they should be. It can create arthritis. It can trigger autoimmune diseases, because it just creates massive amounts of inflammation. High heart rate, low heart rate variability. So just generally, like, your heart is having to pump and work harder than it should, because your body's underneath a tremendous amount of stress. It can cause diabetes. In fact, the term, I don't know if you've ever heard of the term bronze diabetes, but that is hemochromatosis, because the high iron destroys the pancreas, and it'll create diabetes, insulin resistance, metabolic disorders, hormone issues. But then the iron gets into your skin, and it creates like this bronzing of the skin. And so, long time before they had, good testing for labs and whatnot, the term bronze diabetes was used for people that had hemochromatosis. But it really can look like just about anything. And The problem is often people just kind of write it off as something else, or most people, they might get diagnosed with a symptom. Let's say somebody gets diagnosed with gout, and the gout is being caused by having high iron. Well, they're basically getting diagnosed with, the secondary or the tertiary problem and not the primary issue. And that's the most common scenario for people with hemochromatosis. Like, rather than being diagnosed with hemochromatosis, maybe they'll be diagnosed with chronic fatigue syndrome or fibromyalgia, because it'll create muscle pain. If, iron also really likes to go and destroy the brain. So it can cause bipolar, it can cause depression, it can accelerate Parkinson's and Alzheimer's disease, it can cause thyroid issues. And so it can really cause just about anything. And women are particularly kind of complicated because women often, although I have seen females of childbearing years that do become high in iron when they're menstruating and having children, which is a very iron demanding experience when you're, losing blood every month through menstruation, especially if you have a heavy period, or having, a child, you lose a lot of iron that way. So, but I have seen females that during those childbearing years, they do become high in iron, but it's not as common. What's more common is that people that have these hemochromatosis genes that are females, it doesn't become an issue until after they're postmenopausal or perimenopausal.
I was going to ask you that, because in perimenopause, and for some women who are flooding and who are obviously, maybe they're getting their periods longer, shorter, like they're still cycling, and in some cases heavy cycling, or have heavy bleeding. Is it something that you can even diagnose in perimenopause, or is it something only that comes into play when they're in menopause? So I was just going to ask you that question.
Yeah.
So I'm so happy you brought it up.
Yeah, it's really different for everybody, and that's where we have to kind of let go of if we just hold on to, let's really look at that iron panel and the CBC and the CMP and get people's genes, then that's kind of where we have our foundation for answers, and that'll tell us if your iron's high. And then, ultimately the health problems that are a result of high iron you may not entirely know that they're from high iron until maybe perhaps you get your iron levels into a healthy range, and then you feel much better and that health problem goes away, ideally. Now, there are cases where if you've had this intense iron-induced damage for a long time, there's irreversible damage, and that's what, we need to avoid. But yes, there's so many environmental factors that cause and prevent high iron. And females are really at the epicenter of that because of childbearing and menstruation. So, but what we do know, perimenopause, it depends on, are you bleeding more? Are you bleeding less? Do you have fibroids? Whatever. Postmenopausal, we know they're not going to be bleeding as much, right? They're not bleeding
at all,
unless they have like a GI bleed or something, right? So that is gone as far as postmenopausal. So that's where a lot of women, they'll start slowly, their iron levels will start creeping up, and these women might have even been anemic years before from bleeding and menstruation, or maybe they were taking a prescription that decreased iron absorption, like an acid reducer or something. There's so many environmental factors. That's where you kind of have to break it down, and I do that in the iron curse and charts. But basically, postmenopausal females tend to catch up with males, especially if they have those hemochromatosis genes, but males tend to have more of a problem earlier in life because they don't menstruate.
So what I'm hearing is it's important to know whether or not you have this gene, because by the time you get into menopause, it could pose a problem, because if you're not getting these blood tests done every year, the longer you had it, the longer somebody has it, the more damage it could create. So it's really good, whether you're in perimenopause or you're in menopause, ask your doctor for those blood tests, find out, what your iron levels are, your ferritin levels are, and make sure that if they are high, is there a number, Dr. Sutton, that we should be, so when it comes to thyroid, so we're saying, it reminded us a little bit about thyroid. We know that there's the normal range and then there's the optimal range. Is that apply here for iron tests as well?
Yes, but before I answer that, I just wanted to kind of address something that you made me think about with what you said. And that is that, yes, postmenopausal females are at a higher risk for having issues with high iron, but this can affect them at any stage in their life. So, for example, I diagnosed a 5-year-old girl with hereditary hemochromatosis. It was causing severe neurological problems.
Oh, wow.
And so if you have this gene, you're at a higher risk for high iron throughout your whole life. It's just that risk can be muted and decreased by menstruation. But I have seen a number of menstruating females in their, teens, 20s, 30s, 40s that become high in iron when you wouldn't expect it. And it's largely just, genes plus environment. It's the perfect storm.
Mm.
And if you do have one of these genes, this is hereditary, you need to check your family members. And this is in all different ethnicities, although it's mostly in Caucasians of Northern European ancestry. That's because the gene started in a Celtic Viking ancestor, and then it came down and it, spread throughout the world. But it's particularly in high concentrations in Ireland because the Irish people have a lot of Viking Celtic ancestors. Plus, they went through the Irish potato famine, which created this bottleneck where the people who had this gene were more likely to survive, and the people without this gene were more likely to die. So, a lot of the gauntlets of evolution come down to iron, and that's why this gene exists, and that's why so many people have it, because it's actually helped you to have more children. And if a gene helps you to have more children, you're more likely to have more kids and they'll pass the gene down. So especially in a world where we didn't have iron added to our foods, no iron fortified foods, no iron prenatal vitamins, no iron supplements, we couldn't go to McDonald's and get a hamburger with, iron rich meat. It was a world where famines were common, bleeding. Women commonly died from blood loss from either, heavy periods, menstruation, childbirth. There were so many things that caused basically this gene to do so well. So that's that. But your question, which is a wonderful question, was, are there these functional ranges? And yes, there are functional ranges. Now, one of my biggest pet peeves is that, if you order an iron panel, this is a really good question. I'm glad you asked it. If you order an iron panel and it has the iron saturation, then that iron saturation almost always allows people go up to 55% before they flag it as high. But the hemochromatosis cutoff is 45%. So why don't they lower that range down to 45? I don't know, but it's allowing so many people to have undiagnosed hemochromatosis. And that's just something that we have to teach people so that they don't fall into that trap of, okay, it can go up to 55. 45 is the cutoff for iron saturation. And then when you have that 45 iron saturation combined with a high ferritin, that is the diagnosis of hemochromatosis. High iron sat at 45 or above, okay, and ferritin high. Now, ferritin range is much more complicated because some labs will allow you to go up to females 125, males 150. Some labs will let males go up to the 300 or 400s. Some doctors are comfortable with ferritin in the thousands. I don't understand that, but it's a real thing. So ferritin in 1,000 is not okay. My cutoff, if I see an iron saturation over 45, at 45 or over 45, or even near 45, like 43, 42, whatever, and then a ferritin at above or near 100, then my alarm bells are going off, and there is no reason to not start really investigating this, because if they have that hemochromatosis gene, it's only going to go up most likely. And there's so many things you can do to lower it with diet, nutrition, lifestyle, and most likely they're not going to get diagnosed properly, which means they could, if you don't if you don't intervene when you see that combination, this person could live the rest of their life undiagnosed with this. This could kill them. So that I see that as an opportunity to intervene and really educate them and say, we have to get these genes, and there is nothing that's going to hurt you about lowering iron right now where you are. There is no reason to go any higher. And if you do have this gene, you will most likely go higher, and it can and will destroy, if not your health, then the health of maybe one of your loved ones if you have this gene.
Wow. I find this fascinating. A good friend of mine, and she's a thyroid expert, Danielle Métive, and I'm going to have her on the podcast as well. And she was on our summit last year, and she was telling me when I interviewed Dr. Pearls and we talked about iron levels and not having too high levels, she was telling me that her levels were like 250 at one point, and she said she was never flagged. So once she listened to our interview with Dr. Pearls, and her and I, we start geeking out on all the science and the research. She's like, oh my God, like she went to give blood, and she did all these things to really lower her blood iron levels, because her ferritin levels, because this information isn't really that at least I didn't know about a lot of this stuff. So that's why I'm so happy we're talking about it, because for those who are listening, now you have a plan. Now you know that you have something you can look into, because a lot of the symptoms you're talking about, Dr. Sutton, are very common menopause symptoms, perimenopause and menopause symptoms. Like everything overlaps, right? So I always share with our audience, there are certain blood tests to get, and ferritin is always one of those blood tests that I recommend hands down, along with vitamin D and our thyroid and our B12, and we've got our standards. So I love the fact that you're kind of digging a little bit deeper into it. So for most of us who go to our doctor and we say, okay, can you please check our ferritin? Would that, I know it's not enough, and we want to do the deep dive. Would that be enough of a signal to even prompt our doctors to go a little bit deeper? So I guess if we're going the doctor route to get the blood test, second question is, can you do these at home? Like, do you offer these as, does somebody have to go to their primary caregiver, or can they get it done through other means?
Yeah, so these are really good questions. So I don't accept insurance, so I can do whatever I want to do as long as it's within my scope. And within my scope, I can diagnose pretty much anything. What I can't do is I can't necessarily treat anything. So I can diagnose hemochromatosis all day, but then I have to refer out for the treatment. And the reason I wrote the Iron Curse is because I kept referring out for the treatment, and the doctors that I was referring out to kept getting it wrong. And then the patients were, lost in, well, she's saying this and they're saying this. And so I just wanted to lay it all out in the line and say, this is the reality. Here's the 600 references. And, this is my experience. Here's the case studies. So as far as me, I order, whatever I want, and I never feel comfortable personally just ordering a ferritin, because ferritin is not a reliable blood marker by itself. You can actually be anemic and have a high ferritin, and that's called anemia of inflammation, because ferritin is also an inflammatory marker. So you can have a high ferritin from high iron, but you can also have a high ferritin because you just have a lot of inflammation, and that can actually cause low iron. So if you're not looking at all the labs we talked about, then you're really like selling yourself short. And we're really talking about minimal amount of dollars here that could save you, decades of damage. So the cost benefit analysis, I just can't really get very excited about that as far as like ever not ordering those. I think it's just really a fallacy within the medical paradigm that needs to be undone, like a lot of other fallacies within the medical paradigm. So now what my plan is, once I publish the book, I always, think people need to work with a healthcare provider like yourself, to look over labs and, really create a plan. But my plan is for those people, and I'm realizing there's more of these people out there, that they are trying to work with their doctor, and they're trying to get their doctor to order these labs, and they're not always able to. And so my plan is to hopefully have a link where they can go and get that done themselves. Although they still, I recommend working with a healthcare provider always. But I think at some point in time, you have to give people the tools to help themselves if they can't get the help through the, required normal routes.
And then and if they have questions, someone can come to you to go over the lab results. Like,
Yeah.
Okay, so they can do that. So we're going to put all your information below. Okay, let's talk about ways you alluded to it before. Let's talk about ways that if you know that you have high iron levels, how can we, you talked about giving blood. What are other ways that we can help to reduce the levels?
Yeah. So blood donation is a really fast way to decrease iron, simply because most of the iron is stored in our blood as hemoglobin. And so that, if you're losing blood, it comes out very, very quickly. So if
How
you,
often?
now that's based on labs.
Okay.
Removing blood is a medical procedure. If you go to donate blood, they're always going to check your CBC to see if you have a high enough red blood cell hemoglobin hematocrit. They don't do an iron panel. They always look at lipids too, usually, but like cholesterol and stuff. But in my opinion, I don't think anybody should ever donate blood without having that full iron panel and CBC, which the blood donation centers are not going to do the full iron panel. So if, I always like to order it before people go and donate blood so that we know, is this actually the good thing for you to do? Or is this going to harm you? Because you can remove too much blood and then you become anemic, and that's not good either. And unfortunately, the modern medical models for hemochromatosis and high iron overload, they really only primarily use blood removal as their primary mechanism, which I think leaves a lot of valuable options on the table. And we can talk more about those in a second. But if you're just using blood removal as your primary treatment, then you're more likely to cause people to get anemic from low red blood cells, low hemoglobin. They can still be high in iron, but it's just they're anemic, they don't have enough red blood cells, and then they can't remove any more blood, and then they're kind of stuck in this holding pattern where they have to wait until they can have more blood removed. And occasionally the doctors will give them like these chelating agents that have lots of side effects. So what in the iron curse I talk about, I have the iron curse protocol. So the first step is remove blood if you can, and if it's the right thing for you, see a hematologist, have a primary care doctor work with you on that. Even if you can't technically donate blood because maybe you have like an infectious disease like Lyme or HIV or hepatitis, you can still get a therapeutic blood removal where the doctor signs the script, they remove your blood and they throw it away rather than give it to somebody. So there's always a way. Hematologists, they can always remove blood, and they can remove as much as they want. If you just go to the donation center, they're going to take a pint of blood out. Hematologists, they can remove a little bit more, a little bit less. So that's kind of a nice resource to have. Now, what you're probably wondering, and your listeners are probably wondering, is, well, what are the other options other than blood removal? And there are many. The second step is diet. If you have high iron and you need to get it down, that's probably not the best time to go and eat, a steak. I think people can still eat iron-rich foods once they get their iron in a managed level, but realistically, if you're trying to get your level down, it's like, why would you add more to the equation at that moment in time? It's kind of like if you're trying to empty the bucket, stop pouring water into the bucket. So shellfish, steak, really high in iron. A lot of people think spinach and vegetables are also really high in iron. They have non-heme iron, which is not absorbable for the most part. Like it's moderately absorbable. It's much less absorbable than heme iron, which is what's in animal products. So like vegans, vegetarians don't tend to have as high of iron. I'm not saying be a vegan and vegetarian. I think there's a lot of issues with that as well. But I'm just saying, I don't think people necessarily have to avoid iron-rich foods because especially if it's like a vegetable, because if it's a non-heme iron, then you're not going to absorb that much of it anyways. But certainly, avoid processed foods with lots of extra iron added to them. And then what everybody always wants to know is, well, what are the supplements? And so and I do have a lot of experience with supplements, and there are a number that I have experience with, and I talk about them in the book. And those include curcumin, which is curcumin is a great anti-inflammatory herb. So if you take turmeric, like what they make curry out of, Indian curry, and then you extract out the anti-inflammatory medicinal property,
Yeah, the
Yeah,
activator.
that's the curcumin. And so the advantage to the curcumin is you get way more anti-inflammatory, like per, milligram, but you also take out the oxalates. So turmeric has a lot of oxalates in it, which is okay if you're eating it in a moderate amount. But if you're trying to like be therapeutic by lowering iron, lots of turmeric could create some issues. So the curcumin doesn't have the oxalates. So, but pretty high dose of therapeutic curcumin can be very helpful. That is an iron binder. It can also bind to copper, so you need to also like look at that and make sure you're not getting too low on copper. But that's a great way to both lower iron, and it can also help to kind of get the iron out of the tissues, because a lot of these people, they start depositing a lot of iron into their tissues. So, and curcumin's wonderful because it's been shown to help with, Alzheimer's, dementia, liver damage, just general inflammation, and a lot of the issues that are related to hemochromatosis. So what I've done with the iron courses, I've tried to replace like natural, well-proven medical research nutritional herbs, vitamins, whatever, that can be iron reducers as chelators to replace those the medical chelators, which have a lot of side effects. So curcumin's one, but then you also have to be careful. Like me personally, I tend to be more anemic, iron deficient anemic, because I have Crohn's, celiac, and part of my intestines is removed from Crohn's. So I'm a menstruating female, so I tend to be anemic. So I have to be careful. I want to take curcumin, but if I take it, I have to take it like away from meals because it'll make me anemic. So these are things you need to be aware of, like as a female. So curcumin's a good one. Silamarin's a good one, because silamarin also, silamarin from milk thistle. So not only is this going to bind iron and lower iron, it's been proven to do this in the research with hemochromatosis patients, but it's also going to help heal up the liver, which is a big deal because people with hemochromatosis, hereditary hemochromatosis, are like 200 times more likely to have liver cancer. This is not a joke. They have to take care of their liver. And nowhere in the current medical model are they talking about what are we going to do to heal up the liver. It's just let's get the iron down, when there's all of these nutritional supplements you can use to both get the iron down but heal up the liver too. And so that's one of them.
Love milk thistle. Milk thistle. I'm so happy you mentioned it.
Milk thistle is a good one for binding iron. Alpha lipoic acid will also bind iron and chelate it and lower it. And then, alpha lipoic acid is so wonderful for like peripheral neuropathy and lowering blood sugar. I personally can't take it because it lowers my blood sugar so much that I bottom out. So if you're like a low blood sugar person, then, maybe not a lot of alpha lipoic acid. But if you're a high blood sugar person, which a lot of these hemochromatosis people are, because the iron often destroys their pancreas and creates diabetes and metabolic syndrome and insulin resistance, alpha lipoic acid is one of those things that we're not only giving you this amazing antioxidant, but we're also giving you something that's lowering iron, fixing the primary issue, and protecting your nervous system and your neurons and your myelin sheaths from damage and lowering blood sugar. So, that's another thing. And I have like a nice chart at the end that kind of breaks all this down, so you don't have to memorize all of it. There's probably like 6 other things I could go through right now. I don't know how much time you want to go on this.
Why don't you take us through them? And my question is, as you're mentioning this, and it could be in the book as well, is what are the dosages? So, we hear, take this, take that. So, and I can't do high doses of curcumin either, just from a genetic standpoint. So I always say, listen to your bodies, because that's really important. And I love that you're giving so many options. So let's go through the other options, and then just touch on whether there's actual dosages that they should be taking, so, because I think that's important, right? It's not 1 or 2 capsules. It's here's the dosage that has been proven according to the science to actually help chelate the iron from your body.
Yeah. So one of the things is that a lot of the research has been done on like mice. And so the dosage that they used on a mouse, is a much, would not be therapeutic as well in a human. So, but there are some where dosage is really key. Personally, the way that I approach it is, for a curcumin type thing, I like around 3 grams a day. 3 grams has been shown to be a good dosage. Having said that, I think you have to leave room for, you know, individualizing for that person. And as their iron levels get lower, getting them off of that, because you don't want to, and I have seen this happen, cause somebody to go from one extreme to the other, like high and then low, just based on the supplements alone, not even with removing blood, just, you know, they had high iron, they have hereditary hemochromatosis, they took all these supplements and now they're low, you know. And so that's where you kind of have to figure out, that's where you need to retest and see, is this too much? Is this not enough? So yeah, for curcumin, I think 3 grams a day, which is usually about 6 pills a day, is a good dosage. But it's just like, you have to look at the individual with every single one. The good thing about a lot of these is that there's, I'm not going to say there's no side effects, because, and I talk about, you know, the considerations of, like, I talked about the low blood sugar with alpha lipoic acid, you know, there's things you need to be aware of because there could be an unintended side effect. But it's, the side effects tend to be not as serious and easily resolved. They tend to be less serious and more easily resolved just by, you know, stopping them. And the side effects might be like, oh, my blood sugar got too low, which is a serious issue. But again, you know, just stop taking it and it'll go back up. The, what else? Within that, there is resveratrol. Resveratrol doesn't actually lower iron, but it does, it's been shown to protect the heart from iron-induced damage. So there's less, and resveratrol is so great also for women because, you know, it's naturally estrogenic, mildly, not a lot, like very mildly estrogenic, and it's been shown to be good for, you know, bone density and stuff like that, and even have a little bit of a mild estrogen effect in females and males too, which can be good for females that are, you know, postmenopausal and dealing with slumping hormones. But it's also really good for the brain and really, really good for the heart, especially for people with hemochromatosis. And it can help them to not have as stiff as a heart, because once you get a lot of iron and inflammation in there, it gets fibrotic and then your heart gets stiff. And then when your heart gets stiff, it's hard to, you know, have a good heart rate and heart rate variability. And it's like the elastic just wants to break rather than, the rubber band wants to break rather than recoil.
I just want to make sure this is for women and men, right? Because, you know,
yes.
Okay, because when you were talking about the levels, is it the same? So for optimal levels, would it be the same? You know, you're looking at that ferritin. So to be clear, it's to have that ferritin under 100, right? That's really where
Yes.
you,
Yes.
okay.
So most labs allow ferritin to go higher on men, but that's not because it's like okay for men to have a higher ferritin. The reason that labs allow ferritin to go higher on men is because, like, if you look at the bell curve on labs, they basically, they do a bunch of people's labs and then they create a bell curve to say, okay, this is a normal range for, you know, 10,000 men. And the normal range is higher on men because men tend to have higher levels of iron because they don't have, they're not childbearing, they're not menstruating. And so their range often allows them to go up higher, but there's no like physiological reason that they need a higher level of ferritin or a higher level of iron. But the ferritin is almost always higher for men. My personal functional ranges for ferritin, I don't feel like anybody needs to be above 100. If they are above 100, I'm trying to figure out why and how to get it down. And then I'm looking very closely at the other iron levels and the inflammatory markers and the CBC and, you know, everything. I have yet to be convinced why there's a good reason for somebody to have a ferritin over 100, because if you have a ferritin over 100, you're either, you know, have high iron, which can cause inflammation, or you're just inflamed. Either way, it's not good.
Would there be a menopausal range for women? Like, so is there, can we go too low in ferritin, or would you say, you
Yeah,
know,
I mean, everybody can go too low. So I also think the lower end of the range on ferritin is too low. So postmenopausal females don't tend to go too low on ferritin unless they have like a GI bleed or something. post or, start bleeding fibroid or something, postmenopausal women, in my opinion is that I don't particularly like anybody to be below 30 on ferritin. And I don't think that matters, if you're premenopausal or postmenopausal. I don't want anybody to be below 30 on ferritin. I think you need a little bit of a buffer there, minimum of 30. And somebody that doesn't have a hemochromatosis gene like myself, I would really like to see, the ferritin more around 60 just to really give them a nice buffer. Now, for somebody that has a hemochromatosis gene, has a history of high iron, I think for those people, you can comfortably, and this is what hematologists do, they will comfortably manage them in a lower ferritin range, somewhere around 30 to 75 or so. But they have a buffer. They don't want it to go too low and they don't want it to go high. But, really that range, it kind of depends on what the genes are and the person, but I don't really see why we would need to change that over 100 and below 30 for anybody. And then maybe little kids.
Right. And then pretty much anywhere in between then. So if you're 30 to, let's say max 100, 30 to 100, then you're kind of in that optimal range, or is it 30 to 60 for clarity?
So yeah, really, I think if you have like a history of high iron hemochromatosis, I think probably 30 to 60, 30 to 75, I think is a good range for everybody, period. If you have a hemochromatosis gene, then there's more of an incentive to kind of get it lower because we know where this is going and it's not going in a good direction and it can get really pathological very quickly.
Dr. Sutton, this was so informative. So I want to talk about methylation, but we went the full hour just talking about iron, which is amazing. So here's what I propose. I would love you to come back.
Yes.
Because I would love to do an entire episode on methylation. I think it's super important. We could talk about genetics. We can talk about all of that. So yes, I'd love that.
Yes, I would love that.
Thank you. I'd be very grateful for that. So is there anything else you'd like to talk about your book? Let people know, where can they find it when it comes out? Tell us where they could find you on social media. And if there's anything else you'd like to share with our audience before we go.
Okay, thanks. So, ironcurse.com is where you can, learn more about the book and the workshop. And then if you just kind of want to know more about all the different things that I do and, schedule an appointment or whatever, then drchristysutton.com is, a good website for that. And Dr. Christy Sutton is my Instagram, and I'm on Facebook and TikTok and all the normal ones.
I love it. Well, keep doing what you're doing. And I found you on social media. So you and your team are doing a great job. So keep it up. And thank you for helping all of us. And thanks for being on today.
Thanks. I really enjoyed it.
That was a really informative interview with Dr. Christy Sutton. I hope you enjoyed it. If you did, please share it because the more you share shows you care. And please write a review for our podcast, Menopause Reimagined. I read them all, but also when you write a review, it tells whatever platform that we're on that you're enjoying our podcast, and they send it out and recommend it to more people. Thank you for listening, and I'll see you at the next podcast.